enjoy this talk. We have an interventional ultrasonographer in our lab, and I'll explain to you what that is. So, in 10 minutes, I'm going to try to do this. So, please bear with me um, going through some of those things through 7 points. Everybody talks about ultrasound as a fellow right now. If you're not accustomed to using ultrasound in your hands or there's resistance from your attending, then you are not getting adequate training. So if you're working with Dr. Prakash Krishnan, so let me know, and we'll have you come our way. But obviously, the data for arterial access has been over and over. I'm just showing you examples, so I don't think there's any room for debate anymore. That using ultrasound, I know it's common sense, but we need data. So that using ultrasound is very helpful, and that actually extends into pedal access. So not everybody is experienced in using fluoroscopy and obtaining pedal access. So using ultrasound for obtaining pedal access absolutely increases the benefit, decreases the risk of complications for a lot of those patients. And this has been shown in multiple trials. In fact, in centers that are experienced with obtaining pedal access, the duration that it takes to obtain pedal access via ultrasound is smaller than common femoral artery access, and the complications associated with it is extremely lower. All right, so access evaluation. This is very important when you're dealing with very sick patient population like CLI or coronary artery disease patients. Vessel pulsation, vessel compressibility, vessel sizing, antegrade access, and closure techniques. All of that information you're going to get from visualizing the vessel, as you can see here. Is the vessel pulsatile? Am I able to compress it with the ultrasound probe? Is there calcium there? Well, why does that matter? This is this example. On the right-hand side, you can see that there's non-compressible area between 11 o'clock and 7 o'clock. On the left-hand side, it is a compressible vessel. So you're not going to be able to access this blindly, the vessel on the right side, except at 11 o'clock. So basically, microscopically, you need to access it there, and that's important. Not all vessels are healthy, especially CLI. Excuse me. I'm not sick. I just had bronchitis, and I took my shots. So sorry. You need to evaluate these vessels as you're obtaining access. You can direct the wire for antegrade access. It's very common for CLI work that you're going to need comfortable with antegrade access. So directing the wire from the profunda to the SFA can be done under ultrasound guidance. Actually, you can turn a disadvantage to an advantage. So an occluded common femoral artery in a CLI patient, and yes, you're going to get those patients. So you can actually use ultrasound because fluoroscopy is not going to be helpful. What you see on the bottom of the right screen, this is the common femoral head. This is the bone. I know this is a compressible site. It's a hypoechogenic space. This is not acute. This has been going on for a while. So I can puncture the occluded vessel into the patent segment of the common femoral artery and take a high complexity case to a much easier, a much more comfortable case. All right. CTO crossing. This is an 035 Navicross catheter being advanced under extravascular ultrasound, basically navigating the chronic total occlusion. And this is our interventional ultrasonographer, holding the probe and watching us as we're advancing the catheter. This is something that you probably need to get comfortable with for the first 3 to 6 months of your training. And after that, you're able to navigate and use these wires and catheters under ultrasound. You can actually use ultrasound. What you see on the left-hand side, this is the pedal access sheath, and we're removing it. This is the wire coming from the right-hand side. We're advancing the wire beyond our access point within the plantar circulation, all done with zero contrast, with zero ultrasound. And this is not a rare occurrence. This happens in each and every case that we have with our patients. How about treatment assessment? This is an osteal SFA lesion. Well, with the self-expanding stents, you can never really land the proximal zone of placing the stent. I mean, there's a lot of excellent skilled physicians, but with deployment of a stent in a retrograde fashion, you can actually see where is the osseum of the SFA. You can actually pull the stent back, as you can see in the left-hand panel, and ultimately place the stent, the self-expanding stent, at the osseum of the SFA, not jailing the profunda in any way, shape, or form, and getting an ideal location. Complication management. I had the pleasure of having this complication early on in my career. I cannot blame any fellows, but this is a patient that presented 30 days after intervention we had on them, just with discomfort in the thigh. And my ultrasonographer was running down the hallway saying, we broke the artery, and we did. But we use ultrasound to basically guide us in terms of finding actually where is the vessel is, and we placed a covered stent across, and we're able to address the issue for this patient. Embolization. This is a debris. You can see the arrow. This is the tip of the catheter right there. This is the 5 French catheter, and this is the debris right there. And this is in real time. I'm slowing it under ultrasound, and we were able actually to capture that debris in real time. We can see it. It's a filling defect on angiography. And when we aspirate, you can see the debris going into the catheter, and I don't have to worry about it. This is a rare occurrence. This is not very common in the practice. How about closure? This is a per-close closure device in an antegrade fashion. We're deploying the foot plate of a per-close closure device against the anterior wall of the vessel. I am comfortable that my device is there. I'm not puncturing a plaque. I'm not puncturing the posterior wall. I'm comfortable deploying the per-close closure device there and not having a complication for the patient. None of our patients leaves the table without scanning their groin before they leave the cath lab. How about pedal access? So we do a lot of a TAMI technique. My next talk is going to be about that. So we do ultrasound-guided modulated closure of access sites. So our ultrasonographer will hold the probe, the hockey stick probe, and actually monitor the flow beyond the access point, making sure that you're not occluding the vessel completely. Don't forget IVUS. I'm just going to mention IVUS to you. This is an angiographic image. I don't see where the takeoff of a posterior tibial artery. So what do? We actually use the intravascular ultrasound to show us the takeoff of a posterior tibial artery. And you can see on the left panel the dimensions of the TPT change to the perineal and the PT. And we actually decide that this is the takeoff of a PT, and we actually approach in an integrate fashion. This is an end-stage plantar disease patients that are going to end up with an AV reversal. So we end up treating the arterial side, excuse me, for this patient. We treat the PT takeoff for this patient, and we do actually kissing balloon angioplasty here. We prepare this patient for AV reversal. This was a stage intervention. And let me show you ultrasound-guided AV reversal. So the concept of the white stop sign, basically, when you see the vessel looking like this on the ultrasound, there is nothing you can do to salvage this arterial conduit. We learned that the hard way throughout my career, that when I see this is a white stop sign, complete obliteration of the vessel. That means that the artery is completely destroyed. There is no surgery. There is no endovascular therapy that can be performed on that vessel. How about extravascular ultrasound-guided arterial venous reversal, where we connect the blood flow through the artery into the vein? What you see on the right panel is a balloon in the artery, and below it is a balloon in the vein. We access the posterior tibial vein, we access the posterior tibial artery, we inflated the balloon in both conduits. And we use ultrasound to basically puncture the artery, puncture the balloon in the artery, continue puncturing, as you can see in the middle panel and in the last panel, all the way to the venous balloon on the inside of a vessel. So now what you have is a needle through the artery, through the vein, and you can advance your wire that way. So it's a little bit tricky in terms of what you need to do. But basically when you look at the right panel, you externalize that wire from outside the body into the vein, and there is actually some elegant techniques by our interventional radiology colleagues, Dr. Tumala, have done some of these where they actually use 2 snares and they connect them with each other. But here in this example here, we use actually an 018 catheter, and we cross from the vein back into the artery, and we perform balloon angioplasty, and you can see the connection between the artery and the vein. When we first started doing this, we thought that they were going to end up with a massive bleed in the area, and what's interesting is you don't. You actually see an AV fistula there and not significant bleeding. And when you talk to our surgical colleagues, it has to do with the fascicle that combines the arteries and the veins together. And ultimately, you treat this patient. It takes a lot of time, and you need a very experienced podiatrist and a wound care specialist. What we've learned in our case series that we're going to publish soon, when these patients end up being seen by physicians that don't necessarily take care of these types of problems, the patients end up with an amputation, unfortunately, despite all of your efforts. The fellows, I encourage you all, if you're interested in CLI work, Dr. PK is actually, he doesn't know it yet, but he's going to be moderating the next meeting. So I hope you all can join us, watch some of these cases, learn from them. I thank you. I'm going to stop here. So I'm the one that's stopping your break. So thank you.